Dr. Shivapilla, do you want to on your microphone?
Yeah, okay.
Thanks.
And I have the pleasure of inviting Dr. Zulma Tovar-Spinoza to give the next lecture, which I think, yeah, that's it. She's going to talk on laser therapy, and she is the director of pediatric surgery at the State University of Syracuse. So, Dr. Zulma Spinoza, please take over. Thank you.
Okay, now can you hear me?
Yes, please. Thank you.
Yeah, that's good.
Okay, thank you. So I want to start by thanking the invitation for this. I will try to resume in 15 minutes, something that is longer than that, about the use of laser ablation in pediatric neurosurgery. Oh gosh, this is not moving now. I have a disclosure and a consultant from Monterrey's. So LITT ablation is a system that has been out in the market for probably since 2010. In pediatrics, we started using this in 2012, and it's just a system, it's a minimally invasive technique that uses a small laser that you insert into a lesion in the brain using a keyhole, either a stereotactic or MRI procedure. And you put an optical fiber that is going to deliver a laser energy or hitting the tissue and eventually destroying it. The question is how we use this in a limited fashion where you can't cause the damage only to the tissue that you're interested to. The laser penetration into the tissue is around 2 millimeters. An additional thermal dose can be achieved through the time dependent. The more that you apply the laser, the longer time, the longer tissue that you are going to be ablating. Usually up to, when you get up to 45 degrees, I always say you get a little bit of a brain fever. After 45 degrees, you start really denaturalizing the tissue. And it's important to have the control of your temperature and do this on a progressive fashion to avoid to get into temperatures of over 60, where I call that the popcorn effect, where the brain really is gonna coagulate and cause a little explosion, and that will increment your risk of post-ablation edema. In the market, there are currently two systems, the Visualize system and the NeuroBlade system in the United States. In Europe, the Visualize system has just been recently introduced. Both of the systems will use diode lasers, and both of them have cooling system. One is a saline cooling system, the other one is a gas cooling system. Both of them obviously are MRI compatible, which is what it makes this technology fascinating, because you can actually see your ablation in so-called real time, because the real time has a delay of 6 to 8 seconds, depending on which system you are using. Important differences from the surgical perspective is that the Visualize system offers you one type of laser that is 1.65 millimeters, and it's a diffusing probe. The lesion, both of them, it depends on how you use them, but it's more or less 1.5 centimeters. The NeuroBlade systems offer you more options, but 2.2 and 3.3 millimeters lasers, and you have diffusing and side fire probes. Obviously, the Visualize laser is more flexible. The NeuroBlade system is more stiff. And the way that this works is literally these days, you can use frame or frameless localization of your insertion of your laser. Initially, you need to put a bolt, calculating obviously your trajectory. For ones who have robot now, a stereotactic ROSA or a stereo EEG, I mean, the laser can follow that same trajectory. And then you transfer the patient with the bolt to the MRI and use the software to introduce the laser and to see your ablation. It's a very simple procedure. What is more difficult is really to calculate what trajectory you want to perform. And this is the NeuroBlade system. It's just to show you that both systems will use a bolt, and then you just introduce a laser, and that is going to hit a determined tissue that you, as the surgeon, are going to decide which one is. There are key factors influencing the accuracy. Obviously, your head needs to be stable to avoid any accuracy data. The MRI nose and face drift, as well as the baseline temperature, are very important because all the calculations are going to be done by the software from the baseline temperature of your patient. So if you are off 1 or 2 degrees, that is certainly going to alter what you are seeing and the effects of your ablation. And you want to have good images and avoid pixel drops on your MRI, because that also will alter the thermography for these patients. In the last 10 years, we have been publishing a lot of single case reports, a little series. This is just now, the last month, where the first multi-institutional thermal therapy for pediatrics are coming out. One is coming out for tumors and the other one is coming out for epilepsy. So how we applied this for epilepsy. So initially the concept was to do the same that we will used to do with open surgery. So we thought that we could use the laser to do disconnective procedures or lesionectomies. So for cortical dysplasias, I will give you just this example of a kid that had localization-related epilepsy to the left cortical dysplasia and schizencephaly. If you think about this surgically, you will go there and try to remove the area. And that was the same concept that we used when we planned for the ablation. So we just put those 2 lasers there and we just ablated from the bottom up all the way to the cortex and created an island of destroying that cortex. And this is the way that it looks on the intra-op MRI. This is the way that it looks on the visualized system while you are doing the ablation. And what you see is that the system is showing the change of colors, and you get this orange color that is indicating that the ablation is done. And this is the way that it looks on the follow-up. You see an island of a tissue that has been disconnected, and this patient did really well postoperatively when the seizure control. Now, hypothalamic hamartoma has become one of the classic indications for laser ablation. And why? Because obviously we all know about the morbidity and mortality of the surgical treatment of these tumors, but also because they are really the specific, great, deep located lesions that you want to treat and you have difficulty doing. The laser will offer you the millimetric treatment without affecting the surrounding structures. Obviously, the experience of the surgeon is very important. This is the way that this looks done on this patient that has gelastic seizures. And that now I'm showing you the way that it looks on the neuroblade system. We have the experience with both of the systems. And as you see, you start seeing these lines here that is just show you different degrees of temperature that you are getting from the heating to the ablated tissue. And post-op, what you see is in the FLAIR images is that an increase of in the intensity. This is another case that we did initially. And just to remind me to tell you that with the ablation, again, when it's hypothalamic hamartoma, you can treat it as a tumor or you can treat it as seizure. My colleague, Dan Corey in Texas Children, has most of the experience with hypothalamic hamartomas. And we know by his papers that you can achieve up to 80% seizure freedom with a median follow-up of 9 months. But also you can just disconnect the tissue. And again, this was done with the visualized system. And initially what we did with this patient was just disconnect the tissue, disconnect the hypothalamic hamartoma. That was one of my initial cases, and it was very conservative. Well, what we got was a seizure-free patient since the ablation with improvement of all the other characteristics of the behavioral disorder a week after, and precursor puberty resolved for months later. I didn't ablate the whole hamartoma, but I was surprised to look in my follow-up images that actually the tumor became smaller over time. Classical indication for adults is mesial temporal sclerosis. We have some patients that we have also seen the use. The report seizure freedom is more or less similar to when you do open surgery. You introduce the laser. Obviously, you try to do your ablation in a pathway that you're going to be able to ablate the hippocampus. Sometimes if you need to get to the amygdala, you might need to add another laser or come back. But it's important to recall that you can also use, before you do your ablation, you can use also electrodes to figure out how far back you need to go using corticography or oscillatory evaluation, fast oscillation analysis, and you can calculate how far back you need to go with your laser. That's what I do every single surgery. I put the depth electrode, and then I measure back with my neurophysiologist, how back do I need to go with my disconnection or with my, my ablation. There is also used for cavernomas technique. We know that cavernomas can present as seizure disorders. McCrane have reported that you can have 80% of control. We are about to publish our series, our first series on pediatric patients, where we have several good results. But with the cavernomas, a lot of people ask me how you do it. The technique changed a little bit. Usually you try to put the laser ablation inside the lesion and then start ablating on that regard. From inside out. With cavernomas, we are much more careful for several reasons. First of all, we don't want the cavernoma to bleed. So you really park your laser in the outside of the lesion, and then you start piercing and ablating as you go in. The other reason is that when you bleed, you change already the quality of characteristics of the tissue. Therefore, your ablation is not going to work, because ablation doesn't work when the tissue, when there is blood, or when the tissue is wet. The thermal heating doesn't transmit through fluid, and that's why it's safe to do it on mesial temporal sclerosis, because it won't cause any vascular effect. This was a case, one of the initial cases that we did when a kid that presented with seizures and a cavernoma on the temporal lobe. It looks very superficial, amenable for open surgery. However, the family was an Amish family that did not want to proceed with open surgery. So we offered this, and it actually really worked. For this patient, we use the laser, the side fire laser. And I was a little bit concerned at the beginning that was not going to work. However, it did a great job, and that's the way that it works. It doesn't go inside, it just surrounds the cavernoma. And with time, what you see is this, again, this disconnection of the tissue. You can achieve the same surgery that you want also to ablate the gliotic area around the cavernoma to avoid that area to keep causing seizures. And in other patients that I'm about to publish, you will see that eventually this space will become like an empty space. You can use a laser ablation, has been reported also for corpus callosotomies. Certainly, you need to find the perfect patient to be able to put one laser horizontal and another one to the splenium and see, and that will be the perfect patient to do it. It's a little bit challenging technically, but it's feasible. So with sclerosis, when we started to use this, they said, okay, well, we cannot avoid patients to have these multi-stage open procedures that we all know are so cumbersome. And then we started using this with patients in single stage, and then or on multiple stages, or even using one single laser or several lasers. Depends on what the epileptologists believe that they were the most active tumors on the determined time. So we will use, our protocol says to attack first the tumors that are more active, and then we will remake the whole surgical reevaluation 3 or 4 months later and see how the rekindling of the brain waves have changed, if the patient had a better seizure control, or we will need to attack the other tumors, and that's how we decided which one next we needed to ablate. All of the patients showing significant improvement, and although we didn't have a perfect neuropsychological follow-up, everyone not only improved on the seizure control, but also on the behavioral control, and we were able to reduce the seizure medications in most of them. And this is the way that it looks. You can put 2 lasers on a single stage, and you can also do several stages, and this was done with the Visualize system. And this is one that we did with the NeuroBlade system on the case of an insular tumor. And this is the result that you look, the way that it looks immediately after, and this is actually an all ablation. So this is how it looks over time, and this is what it looks immediately after on your post-Doppler with contrast. So there is evidence that we can get similar than the surgical outcomes we're using the MRI LITT. However, you know, I believe that we really need to have good training and experience on doing it, like every single new technology. And it's fantastic for patients with mesial temporal sclerosis, hypothalamic hamartomas, and cortical dysplasias. Like everything single pass on an epilepsy surgery, you really need to know what you're doing and what you're disconnected. And as I think has a very beneficial minimal invasive use on tuberous sclerosis patients and periventricular heterotropias and tumors. Obviously, the more that we incorporate new technologies, the more the protocols change and how we do it changes. It depends if you have robots or you don't have robots, stereotactic EEG versus the resources that you have locally. But we have good results with less surgical mortality that are equal to the epilepsy surgery. The limitations, obviously, the first series of big cases are just now going to be published. And as we all know, in epilepsy surgery, you really need to look on what is going to happen in 5-10 years from now in the long term. The other thing is that we need to try to homogenize the standard cognitive quality of life and behavioral results. 2 words about brain tumors. Again, great for great tumors because it's minimal invasive. Family love them because cause minimal disruption. You send the patient the next day. It's repeatable. It's good for benign and malignant lesions. You can coadjuvate that with chemotherapy. It's easy adaptable to the size and shape of the lesion, and can be one single procedure, or you can come back. It does not affect the Karnofsky and is compatible with other therapies. In pediatrics, it's important that it does not use ionizing radiation, and you can use it also as a palliative treatment. We published this series in 2016 with benign and malignant tumors, and some of them presented as epileptic cases. And what is important is to result that you will see the volumetric diminution of the tumor in about 9 to 17 months, and usually after that you get a plateau, and then you need to reassess. This is the paper that is just came out from the multicentric study where both benign and malignant tumors are involved with good results. Again, there are some complications that need to be taken into consideration, and I think the experience of the surgeon plays a significant role on that, but it's an effective minimally invasive option for tumors. Also has proof, and this is another paper that just recently came out from the consortium, that it can usually, even if the Karnofsky is a little bit affected after the laser ablation, it will actually recover and will remain stable. Again, we are getting data from different parts, from different centers. The tissue damage, it's more that I will say tissue dependent and not like tumor dependent, and you will see how the same tumors will react, the ablation will react differently. And the technological limitations from the software. We are little by little working by that, but it's important for the neurosurgeon to have in mind that there is a delay of 8 seconds that you are not seeing, you're blind when you're doing the ablation, and the volumetric data and the 3D, 4D images, you still need, even though with improvements, you still need to have a good idea of what you're doing and what your risks are of not ablating the area. Even though there is 1 millimeter error, you want to have that all the time in taking into account, because you don't want to have ablation of the adjacent tissue. The future directions, I wrote this slide some years ago, but where you see the smiles are areas where we already are working on for thinner calvariums, developing nice bolts for pediatrics. Now we have the ROSA, we have several robots that we are using, and we are using, trying to homogenize the clinical protocol with multicentric centers to make this more pediatric friendly. And in conclusion, this is a great minimal invasive option for pediatric epilepsy or for pediatric brain tumors. And as the technology keeps advancing and we keep incorporating more and more technologies, we keep learning and we keep applying this to more pathologies. Thank you very much.
Thank you, Dr. Zulma. Thank you for introducing us to an emerging technology, which is perhaps going to change this field in the years to come. One question that's been put up in the chat box is whether you do any biopsies before you take up ablation.
Yes, I do. In the case, if the case is an epilepsy surgery, probably we will do first is to put a depth electrode and look at the high frequency oscillation analysis, and then I will take the biopsy, and then I will ablate.
So it's multiple surgeries, is it?
It's the same procedure. It's the same surgical time, but you do that on that order. That way, you don't alter what you're seeing. So you do you look at the waist first. That way, you don't alter the anatomy. Then you take the biopsy. Then you ablate.
Okay. Do you have any size limitation to what you can ablate? Like, do you have, suppose there's a larger lesion, does ablating that cause more edema and more problems?
No, with time, initially you said, you cannot go further than 3 centimeters. I have learned with time that you can actually ablate bigger lesions, but again, you need to control your ablation. You go, when I say it's slow and just increase the temperature little by little, and then you can get bigger areas. Obviously, you don't want to over ablate, have lesions more than 6 centimeters or something like that, because that certainly, just by the minimal edema that you can create a mass effect.
Thank you. Thank you. So I think we are running out of time. So I'll request everybody to put up their questions, both for Dr. Maras as well as Dr. Zulma in the chat box, and I'll request the speakers to answer them in the chat box. Thank you. And finally, let me invite Professor Rutka to deliver the last lecture of this session. Professor Rutka, of course, needs no introduction.